So, without further ado, I'd like to begin with the first speaker, Professor Ingrida from Lithuania, who is a great friend, and she's going to speak about glaucoma as a two-pressure disease, role of IOP, mean arterial pressure, perfusion pressure, cerebrospinal fluid pressure, ICP, and lead the way for the first lecture. Thank you.
Thank you very much for a nice introduction. I have no financial interest in the topic. And I would like to begin with a simple question. What is glaucoma? We all know that it is progressive optic neuropathy causing irreversible blindness. But according to the rules in medicine, we need to identify disease tissues and prescribe specific therapy. It means that we can say that glaucoma is a disease of trabecular meshwork, Schlemm's canal conventional outflow system, leading to IOP elevation. Or we can also say that it is complex ganglion cells, axons, and optic nerve, responsible for structural loss and further leading to visual loss. However, up to date, we have no specific effective therapies for either of the diseased tissues. What we know about glaucoma is, of course, the main modifiable risk factor, intraocular pressure. Intraocular pressure leads to tissue deformation, stress and strain, depending on tissue material properties and geometry in individual subjects, and further on to altered blood flow, nutrients supplied, and leading to ganglion cell loss. Altered blood flow can also be as primary insult, leading to the same ganglion cell loss. And as you see from the scheme, the third player in the game is cerebrospinal fluid pressure, also via tissue deformation, stress and strain, leading to disturbed blood flow, or via translaminar pressure gradient, leading to prelaminar neural tissue thinning. So all these players are having some specific input in the pathogenesis of glaucoma. What is common to all of them is circadian rhythm, 24-hour internal body clock, which not only tells our body when to go to sleep, but affected by different environmental factors, such as sunlight exposure, temperature, seasons, daytime, nighttime variation. They might be independently causing different health problems from a disturbance of circadian rhythm. And again, what can be disturbed? Intraocular pressure, blood pressure, heart rate, ocular perfusion pressure, and cerebrospinal fluid pressure. All three managing factors for circadian rhythm. What do we know about circadian rhythm? We know that IOP is highest at night, but it's actually only in habitual positions. The study was done to analyze the intraocular pressure fluctuations during day and night, and as you see, if it was measured in sitting position, both diurnal and nocturnal intraocular pressures were similar and not statistically significantly different. But what was actually much different was aqueous humor flow, reduction during night up to 50%, and uvascleral outflow reduction up to 93% during night. So that might be the explanation of current treatment for glaucoma when we prescribe prostaglandin analogs, and one drop before the night can increase uvascleral outflow and decrease intraocular pressure effectively. These data cannot be directly extrapolated to glaucoma patients because of different issues what are happening with glaucoma subjects. But in glaucoma patients, we also know that IOP is highest at night, but sleeping with 30 degrees head-up position leads to intraocular pressure lowering. And probably we never know in what position our patients prefer to sleep. But it was analyzed, and several authors showed that 30-degree head-up can lead to 20% IOP reduction in 1/3 of patients, or to 3.2 millimeters in glaucoma patients. So 3.2 millimeters IOP lowering effect just with the head-up position. Another nice examination of effect of head and body position on IOP when intraocular pressure was measured in healthy subjects in sitting and recumbent position. And as you see, the sitting intraocular pressure was 14.8. Neck extension led to intraocular pressure elevation, and especially neck flexion was increasing intraocular pressure. This might be due to venous compression in the neck, increased episcleral venous pressure, or hydrostatic effects. In recumbent position, even worse with intraocular pressure. Only in supine it was statistically significantly different from neutral, and right and lateral decubitus positions were leading even more increase of intraocular pressure due to episcleral venous pressure, choroidal engorgement, or probably intraocular pressure was getting high in the lower eye. What does that mean? Another presentation presented last year, ARVO, they were changing healthy subjects' body position from right upright to right lateral decubitus. Sorry, I'm showing to the wrong direction. Right lateral decubitus or left lateral decubitus. So in this position, we have lower eye, which is dependent eye, and upper eye, which is independent eye. So as you see, in the right lateral decubitus, dependent eye, was having higher intraocular pressure by 2.8 millimeters, and the curve remained stable during 1 hour of observation, but the upper eye was only slightly elevated and the curve was rather flat. In the left lateral decubitus, the situation was even worse because intraocular pressure raised 4 millimeters of mercury. Even in the upper eye, it was 2 millimeters of mercury increase in intraocular pressure. And this is from last year ARVO, but if we look at the literature, cardiologists already wrote years ago what is wrong with the left lateral decubitus position and why is right better. Because heart is left-sided, right atrium is in lower position in the right lateral decubitus compared to supine or left lateral decubitus. So it leads to easier venous return to the heart, attenuation of sympathetic modulation, lower norepinephrine levels, lower natriuretic peptide levels, better aqueous outflow, and of course, lower intraocular pressure. So it comes to the point that we need to know what our patients prefer to sleep in and which position is more comfortable for them to sleep during night. The interrelationship between ocular perfusion pressure and ocular blood flow, usually we are trying to express that in formulation by calculating ocular perfusion pressure 2/3 of mean arterial pressure minus IOP, and also ocular blood flow, which is directly related to ocular perfusion pressure and indirectly to resistance. We know that ocular perfusion pressure can be influenced both with antihypertensive medication and IOP-lowering medication. But changes in blood pressure have a stronger influence on perfusion pressure than changes in IOP. Resistance is usually influenced by autoregulation, mostly in young and healthy subjects. It provides a consistent blood flow over a wide range of ocular perfusion pressure variations during day and night. But in older, this regulation leads to dysfunction and allows any fluctuation in ocular perfusion pressure to changes in retinal and optic nerve head perfusion. During night, we lack physical activity, and decreased demand for oxygen results in lower blood flow and increased resistance. So it is known that physiological nocturnal blood pressure dip is about 10 to 20%. And usually most subjects are dipping heavily during night. But for those who are not dipping or dipping not enough, they have 24-hour exposure of high blood pressure, increased frequency for different cardiac events, and cardiovascular mortality. What is more interesting, recent publication by Michael Cook group, who realized that higher daytime variability of blood pressure and ocular perfusion pressure, and much more over-dipping during night. So it means that not non-dippers are at risk of cardiovascular events, but over-dippers are at much more higher chances for visual field deterioration just because they are over-dipping during night. The third variable, low cerebrospinal fluid pressure in the retrobulbar region. It is known and have been shown in multiple animal studies that probably it has similar effect as increased intraocular pressure on translaminar pressure difference. The problem is that what we are presuming as intracranial pressure or cerebrospinal fluid pressure is actually the system of 4 compartments against the intraocular pressure. And again, if we put all our ideas into formulation and calculate what's happening if we have normal intraocular pressure and normal intracranial pressure, normal laminar cribrosa thickness, So the pressure difference is 4 millimeters, and pressure gradient is 10 millimeters across the lamina cribrosa. But if we theoretically raise the intraocular pressure to 25, decrease intracranial pressure, and as usually it happens in glaucoma, decrease the thickness of lamina cribrosa, we have almost 4-fold increase in translamina cribrosa pressure gradient. So of course, it might be damageable on the optic nerve tissue. The intraocular pressure and cerebrospinal fluid pressure interrelationship comes from the fact that they are both dynamic physiological parameters. They both increase at night in the supine position. And the pressure wave from the heart during systole first arrives to the brain, leading to further pulse-synchronic intraocular pressure elevation. And these fluctuations might be directly registered to analyze what's happening during dynamic fluctuations. Both cerebrospinal fluid and aqueous humor are produced by carbonic anhydrous catalyzed reactions. They represent both ultrafiltrate of blood, and they are nearly identical in chemical composition. So we're talking about very similar things. In the retrospective review of 62,000 patients, Berdell group showed that glaucoma subjects have lower ICP, and normal tension glaucoma subjects, they also have lower ICP. But ICP is elevated in ocular hypertensives. And theoretical idea comes that probably ICP may play an important role in the development of glaucoma and preventing progression of glaucoma in ocular hypertensives. The study by Jonas group used invasive technique, prospective interventional study, and they also found that normal intraocular pressure glaucoma group had lower ICP as compared to control and high IOP group, and translaminar pressure difference in the normal tension glaucoma group was only slightly higher as compared to control group and high tension glaucoma group. So what we are doing in our university, we have a chance to use non-invasive intracranial pressure measuring technique. You will hear the talk by Professor Ragauskas in this session. We started analyzing what's happening with the fluctuations in healthy subjects during the day, and we found no significant differences between morning and midday ICP fluctuations in healthy subjects. But as you see, we have different glaucomas. A normal tension glaucoma group, high tension glaucoma group, and control group were 3 groups of initial examinations that we are trying to analyze what's happening with the ICP. And we found that in normal tension glaucoma group, reduction of neuroretinal rim area was related to higher translaminar pressure difference only in normal tension glaucoma patients. So having this especially interesting issue in mind, we went further on analyzing, and after analyzing 40 normal tension glaucoma subjects, we saw that some of them are having lower ICP and some of them are having higher ICP. So according to mediana, we divided them into 2 groups. And what is interesting, intraocular pressure in both groups were similar, intracranial pressure was different, and translaminar pressure difference was also much higher in normal tension glaucoma group with lower ICP. And even more, if we to analyze further on, rim area and cup area were much more damaged in this group with lower ICP levels. So probably we are having some specific reason for specific sensitivity in normal tension glaucoma subjects who have specific individual variations of ICP and leading to optic nerve damage. At this point, we need to say that we need a virtual lab. As it was mentioned in the keynote lecture yesterday night, that the virtual lab is possible to isolate factors contributors. And if we are talking about all these factors contributors that are interesting for us, ocular blood flow, IOP, cerebrospinal fluid, blood pressure, and autoregulation, we cannot measure them all. Usually it's difficult to analyze them all in living human being. But it is very helpful if we put that and analyze it in the virtual lab. And by Giovanna group, it was nicely analyzed. Alterations in central retinal artery blood flow are affected by low cerebrospinal fluid pressure and elevated IOP in different ways. So these two factors might influence blood flow in two different ways. And what we are now looking forward is to put all these measurements into what is interesting for us clinicians. What's happening with the structural damage in glaucoma? And can we calculate the input of different variables on the optic nerve structural damage and probably on the visual field damage in glaucoma? So, in conclusion, current best knowledge in glaucoma as two-pressure disease and to relationship with ocular blood flow is complex and needs further elucidation. And clinical relevance might be estimated by newly developed technologies and, of course, what we are looking forward and especially interested in, math modeling. Thank you. And this is Kaunas.
Thank you very much, Ingrida, for this nice overview, putting together all the different pressures for us. And this would be a really nice point to turn to Professor Ragauskas, who is going to tell us about measurements of intracranial pressure. Professor Ragauskas is also from Lithuania and is the inventor of the technology that we're going to hear about, of which Ingrida presented some data of our collaboration and work that is done regarding ICP in glaucoma patients. Professor Ragauskas.
Good morning, ladies and gentlemen. I would like to start from many thanks to organizers of this interesting educational and scientific event. I also appreciate very much introduction to our non-invasive technology given by Professor Alan Harris yesterday. And a lot of thanks to Ingrida, because I'm not ophthalmologist. I'm from physics. I'm working with in biophysics many years. I'm working in medical field, in special field, in traumatic brain injury also many years. I'm working with patients which are in coma. But Ingrida is my nice guide and navigator in the field of ophthalmology. And what an adventure for me, because I see a lot of similarities. You are talking about perfusion pressure, you are talking about autoregulation. If the brain is injured, if the patient is in coma, our targets for treatment are cerebral perfusion pressure. We are developing the concept of optimal cerebral perfusion pressure, which is based on real-time monitoring of cerebrovascular autoregulation state. We have technology, other non-invasive technology for that. Other treatment target is intracranial pressure. And intracranial pressure is important in glaucoma as an important biomarker. And there we see application of our non-invasive technology. But today I have to talk about measurements of absolute value of intracranial pressure. When I see, how to say, numbers on the screen, and when somebody says that he is able to manage intracranial pressure according to the numbers, digital numbers on the screen of ICP invasive monitor, and if monitor shows 20 millimeter of mercury, and physician decides that in the patient brain, ICP is equal to 20, that is big mistake. Because at the same time could be 30, and the same time could be 10 for the same patient because of uncertainty, because of random errors, and because of systematic errors, because of limited accuracy and limited precision of every measurement device if you are measuring physiological variable. Okay, I will start from my financial interest. Of course, I have big financial interest in marketing of non-invasive technology invented by me and my team. And we established companies, and our latest development of this business is Vitamed Corporation in Boston in the US. And of course, I'm interested in development of that company. What about intracranial and cerebrospinal fluid pressures? What about, let us say, critical thresholds in the body? Gold standard in neurology is cerebrospinal fluid pressure, available via lumbar puncture. If we are talking about the human brain, gold standard for invasive ACP measurement in neurosurgical ICU is brain intraventricular catheter or sensor. Why? Because definition of intracranial pressure is very simple. This is the pressure inside cerebrospinal fluid. Because of that, I saw yesterday on the screen that ophthalmologists are using two terms, CSF pressure and intracranial pressure. In my brain, that's the same. Invasive measurement of ACP is only available technology at the moment, not very accurate and not very precise. But let us go back and let us think about arterial blood pressure non-invasive measurement. Everybody knows how to do that. And Joseph Erlanger, the person who patented the final version of this technology in 1904, he is professor from Johns Hopkins, he got his Nobel Prize in 1944. What was the basic principle used by Joseph Erlanger for that important invention? Because arterial blood pressure and ICP are two fundamental biomarkers in the human body. You see the basic principle to apply pressure to the artery in your head, in your hand, and to compress that artery, fully compress. And what happens there? We have the scales. We have two pair of scales in this case. Pressure inside the artery and pressure applied outside. It has to be balanced like in scales. And this measurement instrument, pair of scales, has been invented in ancient Egypt many, many thousand years ago. And Joseph Erlanger invented scales again. Comparison of arterial blood pressure and externally applied pressure to the body. We used absolutely the same principle for non-invasive ACP, absolute value measurement. I have to stress on absolute value. You need number, you need independent from the patient individuality number, which means intracranial pressure in millimeters of mercury, in pascals, in torso, whatever you want, but this is number. And if you are trying to create some measurement method based on correlation between something in the human brain or something in the human head and intracranial pressure, it's a terrible mistake. Correlation is not useful for absolute value measurements. I will not go deeply into this problem, but please believe that that's truth. A lot of unsuccessful approaches to non-invasive ACP measurements. Why unsuccessful? You can see into the list of American patents, and you can find 30 years of history of unsuccessful approaches, again, based on correlation or based on mathematical relationship between arterial blood pressure, blood flow in middle cerebral artery, and intracranial pressure. And where is the failure? Failure is always in the same place, in prospective clinical study. Absolutely latest results from Massachusetts Institute of Technology. They just published the result of 20 years of development of mathematical model, nonlinear mathematics, very complicated, sophisticated, which relates invasively measured arterial blood pressure, blood flow measured by Doppler technology in middle cerebral artery, and intracranial pressure. Systematic error going through prospective clinical study. 13 millimeter of mercury, random standard deviation of random error plus minus 10. That means uncertainty plus minus 20. That is absolutely not applicable for clinical practice. My personal conclusions on that. Correlation-based methods is just the guarantee of failure. Mathematical model-based methods are too inaccurate and not applicable until now, after 20, 30 years of development. And I decided to go again back to the definition of accuracy and precision, and that's clear without comments. And just a few examples about accuracy and precision of invasive ICP measurement methods. You see what a terrible random errors. What a terrible uncertainty here. The best, we studied as a brain IT group. I'm the member of Brain Plus Information Technology Group in Europe many years. We studied the best German ROMEDIC invasive ICP sensor, and we found that uncertainty of measurements is plus minus 7 millimeter of mercury. Imagine that you have to keep ICP below 20 millimeter of mercury in neurointensive care unit, patient is in coma, and your monitor shows you 20, but at the same time, that means 27 or 13. What to do, craniotomy or do nothing? That's the problem. This is a result of that study. We published that study in 2008. And going back to unsuccessful approaches, you see that everything is correlated in the human brain, in the human head with ICP. And I will stop just on tympanic membrane displacement. That approach was used longer than 20 years, even private company in America, even investment of NASA, even investment of American Army, and the result is equal to 0 because errors are too big. And other things, ophthalmodynamometry, again, correlation-based, and because of that, inaccurate. And as I mentioned before, our idea is the same as idea of Joseph Erlanger, but we changed just the artery. We found that ophthalmic artery is excellent sensor of pressure, as every other artery in the human brain, but ophthalmic artery, it has two segments. One segment in the brain, covered by cerebrospinal fluid, other in the orbit. And we can easily create natural pair of scales. And this is a little drawing from our very first American patent showing how our method works. Application of external pressure to the eyeball and tissue surrounding the eyeball, and because of non-compressible tissues, this pressure goes to the extracranial segment of ophthalmic artery, and we are balancing the scales. And we are using two depth, very sensitive, very special Doppler device, ultrasonic Doppler device, not from the market, but created by in my institute as a balance indicator. Again, we invented the scales again. Here you see how device works. We are applying pressure to the eye step by step. We are achieving the moment of balance, and we are indicating what is the extracranial pressure, which is equal to ICP in the case of pressure balance. And here are results of our prospective clinical studies. We did prospective studies starting from my very first grant funded by the US Department of Defense, because we started all development of the technology for American Army. After that for NASA and for other applications, and now for ophthalmological applications. And you see that our experimental points from many patients are within error corridor plus minus 4 millimeter of mercury. That's great. This is multi-center study. Again, our standard deviation 2.49 millimeter of mercury. And what is important, that this method, in the same way as non-invasive arterial blood pressure method, it has no systematic error. Fits for everybody. We don't need patient-specific calibration. This is the beauty of the method. And if you like this regression analysis, not blind outcome, the same information is here. If you like ROC analysis, sensitivity and specificity, you see the results here, but that's the same information, just in different form. And to conclude, we achieved good enough accuracy, no need for patient-specific calibration. Precision, we are working on precision, and we can achieve much better precision. Sensitivity, specificity are good enough. Ideal linearity and invariability to many, many influential factors. And the shape of devices, you see touchscreen device, which is a product for American market, which will be ready to launch in the next year. And thank you very much.
Thank you very much, Professor Ragauskas. Just to remind you, I'm going to have all the speakers from the session come over, and we'll have a bit of time for discussion at the end of the session. We also have just a bit of a change because I covered some of the topics I was supposed to cover a bit later. I'm going to, for the sake of time, we're going to expand the session, and we will skip the lecture of my proposed lecture at 11 o'clock. So we'll have plenty of time for discussion. We're going to move on to our next speaker. We spoke about measurements of brain pressure, and we're going to move now to Professor Ulrich from Germany, who I also know for many years. And from measuring the brain pressure, we're now going to talk about a new non-invasive method, the Ocular Perfusion Flow Analyzer, for measuring the ocular perfusion pressure and the ocular perfusion reserve in humans. So it will be interesting to see if these pressures can be measured accurately as well. Professor Ulrich.
Thank you for your kind invitation to this very exciting congress. I would like to demonstrate today a method and a device for measuring the real ocular perfusion pressure non-invasively and easily. It's performed simultaneously on both eyes without dilation of the pupils. To introduce my topic, I would like to show you two monuments, one of Hermann von Helmholtz and one of Albrecht von Graefe. The Helmholtz monument is located in the courtyard of the Humboldt University, Berlin. And the Albrecht von Graefe is located in front of the famous Charité. Helmholtz invented the Augenspiegel, the ophthalmoscope, and Graefe was the first to observe pulsations of the retinal vessels on the papilla nervi optici. This was the birth of the ocular pressure measurement, the sphygmomanometry of the eye. In the following years, numerous attempts were made to develop a clinical usable method to take in ocular blood pressure measurements. Erich Weigelin established the fundamentals for this, but there remained the problem of how to increase the IOP in a defined and repeatable manner that would not be uncomfortable for the patient. By increasing the pressure on the eye with Hager's balloon, as you see it here, or Löw's contact lens, the eye bulb is pushed into the orbit and the orbital vessel becomes compressed, the shaded area. These two methods gave rise to the question of where ocular blood pressure should actually be measured. When the entire orbital circulation is compressed, the measurement point is the internal carotid artery close to the junction of the ophthalmic artery. However, if only the ocular circulation is compressed, the first measuring point is at the ophthalmic artery near the junction of the central retinal artery, and the second measuring point is for the main ciliary arteries. The contribution of the ocular circulation to the entire orbital circulation is only 2 to 3%. In order to obtain exact measurements of ocular perfusion pressure, it is thus vital that the orbital circulation will not be influenced. To To date, there is only one way to do this, which is a Kukan suction cup principle. We therefore developed very light plastic conical suction cups and light hoses that are comfortable for the patient. By means of negative pressure, they attached to the eye without any manual interference. We established conversion curves for the relation between the applied negative pressure and the resulting IOP for healthy volunteers. With our Ocular Pressure Flow Analyzer, OPFA or OPFA, which combines the suction cup method with modern technology and software, we can obtain ocular pulse recordings and at the same time make artificial changes in IOP. This picture shows a patient during the OPFA exam. Following local drop anesthesia, the scleral suction cups are temporarily attached to the eyes through pneumatic coupling connected to highly sensitive transducers and a volume calibration system. By means of a suction pump, the perfusion pressure can be decreased rapidly for a brief moment. Then the ocular perfusion pressure is increased in a defined manner and the ocular pulses are being recorded. And what we get is an ocular pulse curve for the right and for the left eye. The first small pulsation is the systolic retinal perfusion pressure, and the pulsation that distinctly surpasses the small retinal pulsations is a systolic ciliary perfusion pressure, and this is a diastolic pressure. We use software to automatically measure the ocular pulses by comparing the pulse amplitudes with a calibration volume of 1 microliter, so that they are individually and inter-individually comparable. On the right side, you see measured pulse amplitudes dependent on IOP. This is a pulse blood volume curve, a classical autoregulation curve. You see here the autoregulatory range. To be precise, the ocular perfusion reserve or autoregulatory capacity of the entire eye. We call this market point critical point. The ocular perfusion reserve of the entire eye is a sum of pulsatile retinal and ciliary blood supply, including that of the anterior part of the optic nerve. The optic nerve head is nourished from ciliary arterioles of the peripapillary choroid, which are also influenced by IOP. Now, comparison of real ocular perfusion pressure with calculated surrogate values. We calculated the surrogate values in the same way as it has been done in the last 22 years, meaning as a difference between the brachial blood pressure and the IOP of 180 healthy subjects and 170 untreated primary open-angle glaucoma patients, and compared them with the OPFA measured real perfusion pressure values. The table shows you that there is a substantial difference between both. What does this mean? This means that surrogate values should no longer be referred to as ocular perfusion pressures, And as I will show you, they have no physiological or pathophysiological significance for ocular circulation. We worked out a normative database from the data of healthy subjects, investigated dependence on brachial blood pressure, on body position, the influence. Due to lack of time, I can't demonstrate it here, but it is available at the TPM booth. And now, OPFA examinations of glaucoma patients. Data of 48 untreated patients with primary open-angle glaucoma compared with an age-matched group of healthy subjects. IOP is increased and perfusion reserve is decreased. Healthy subjects, here the ROC curves. You see the specificity and the sensitivity. The same for normal tension glaucomas, very low ocular perfusion reserve, and you see results with high accuracy. Ocular hypertension, IOP is increased and the perfusion reserve is characterized by extremely different values, very high on the one hand and very low on the other. The cases with low perfusion reserves are those that will develop into a primary open-angle glaucoma and should be treated. Here, the overview of the outcome of the untreated glaucoma patient compared with the respective groups of healthy subjects. In all cases, you see primary open-angle glaucoma, low tension glaucoma, ocular hypertension. Ocular perfusion pressure remains statistically unchanged, while ocular arterial pressure and the ocular pulse blood volume increase. Perfusion reserve is in untreated glaucoma patients distinctly decreased. You see, you get a typical pattern. Low tension glaucoma is recognized by decreased perfusion reserve, and the transition of the ocular hypertension in primary open-angle glaucoma is also characterized by the decrease in perfusion reserve. How can these results be interpreted? An increase in IOP is followed by an effective ocular vascular dilation accompanied by an increase of the ocular pulse blood volume and an enhancement of the ocular arterial pressure. Due to this vascular regulation, ocular perfusion pressure remains statistically unchanged, thus securing ocular perfusion. Exams after glaucoma treatment. All is going in the other way. You see a patient treated with latanoprost. IOP is decreased and perfusion reserve is increased. Here, the statistics show a highly significant decrease in the ocular perfusion, ocular pulse blood volume, ocular arterial pressure, IOP, and a highly significant increase in perfusion reserves in primary open-angle glaucoma patients compared with an age-matched group of healthy subjects. The OPFA exam shows the treatment effect, improved or normalized autoregulation with high accuracy. Here, results, the same results for Travatan, Lunigan, also Travoprost, Bimatoprost, and so on, also Timolol. Perfusion reserve in untreated primary open-angle glaucoma patients, and here treated with latanoprost. You see at once where treatment failed. Conclusion. Ocular perfusion pressure and calculated surrogate values are not the same. They are not interchangeable. Real ocular perfusion pressure can be measured easily and quickly. We can demonstrate it to you at the booth, TBM booth. OPFA examines ocular blood flow regulation of the entire eye, only of the entire eye. Pathophysiological fluctuations, heavy fluctuations of ocular perfusion pressure are an important risk factor for developing glaucoma damage. Thank you.
Thank you very much, Dr. Ulrich. We're, as I said, we're going to have some time for some questions at the end of the session. We're going to move on right now to Professor Guglielmi, who is going to talk to us about the role of perfusion pressure in glaucoma, the importance of statistical methods. So again, the approach, while we're setting up here, the approach has been an approach of trying to present some of the clinical data and yet to have some of the scientists come in and give us different views, which is something that we very much need in glaucoma in trying to understand these parameters that have been mentioned and measured for many years. Alessandra, it's all yours.
Okay, thank you. Hi to everybody. So let's start from the motivation of this talk. It's well known. Thank you. It's well known that elevated intraocular pressure, IOP, is a recognized risk factor for glaucoma. Among other risk factors, there is in particular low blood pressure. So clinicians have decided to use what is, to me, I mean, it's a synthetic index because it's a transformation of two other variables, the mean arterial pressure, defined as follows here, and minus IOP. So it combines the effect of elevated IOP and low blood pressure. So low OPP represent high risk for glaucoma. So I have a question. Should all this pressure, the MIP, IOP, OPP, be interpreted as risk factors for glaucoma? How? What I mean by risk factors? Well, in this talk I'm going to provide a statistical interpretation because I'm a statistician and try to provide a statistical answer. So from a statistical point of view, the goal of the problem of the data set I'm going to analyze is the identification of, relevant covariates in the prediction of the indicator of a disease, which is of course glaucoma. We have a data set. We have 157 patients from the Indianapolis Glaucoma Progression Study and from other studies at the Glick Eye Institute directed by Dr. Harris. The data set contains some patients with glaucoma and some others which who are healthy patients. We have covariates available. That means that we have some explanatory variables I will show you in a while, continuous or binary. And the response, that is the main variable I'm interested in, is the binary indicator of the glaucoma disease, equal to 1 if the patient has the glaucoma, 0 otherwise. And I would like to underline that the ultimate statistical goal of this analysis is the prediction of the response of a new patient joining the study, that is the prediction of the disease probability, given some covariate, given that it has some fixed values for the covariates. I would like to underline too that this is a toy example, of course, because we have just a small data set. I used this data set to illustrate the meaning of a statistical model and the issue I'm going to present to you. But however, the data are real. Okay, so outline, motivation, I've already talked about that. Data description, very quick. Quick revision of logistic regression models and multicollinearity, if you're not aware of them. Data analysis and a discussion. So these are my data, and you see that the red ones represent data for glaucoma patients, while the blue one represent the healthy patients in the data set, and SIC is the indicator of the main response, is the indicator of the disease. Covariates, well, we have some more explanatory variables, but they were partially available, so at the end we decided to include in the model to analyze only age in year, gender, heart rate, intraocular pressure, systolic and diastolic blood pressure, the MIP I've already introduced to you, and the OPP. So you see from this equation that, of course, this vector, OPP and MAP, is a linear transformation of these other three guys. And when this happens, we have explanatory variables that depends from, that are a function of some other variables, we say that covariates are multicollinear, and this is a statistical issue. Why? Well, quickly, let us revise a logistic regression model. It's a class of model within a larger class of generalized linear models. It's a statistical model, of course. That means that our observed data, that is the main response, y equal to 1 if the patient has the disease and 0 otherwise. So these numbers are realization of independent binary random variables, modeled as follows. So pi I is the probability that the patient I has the disease, and the logarithm of the odds pi I over 1 minus pi I depends through some regression parameters on the values of the explanatory variables in the patient. So by bj, beta j, I denote the effect of the jth covariate on the response, of the jth explanatory variable on the response, while xij is the value assumed by the jth covariate in the ith patient. So usually what statisticians do is to provide an estimate of the vector of parameters, so we have a full vector of parameters via standard statistical methods, for instance, maximum likelihood estimate. The estimate, which is usually denoted by beta hat, requires to invert a matrix, that is what is called the design matrix. It's a n times k matrix with rows given by the vector of covariates. Okay, so what happens if the rank of this matrix is not full, is less than k, as in case of multicollinear covariates? Okay, this means that the columns of x are linear dependent, and this means that the estimate of this parameter, which is the logarithm of the odds ratio between x is equal to xj equal to x to xj equal to plus 1, cannot be interpreted as the individual effect on the odds of the covariate xj adjusting for the other explanatory variables. Adjusting for the other explanatory variables means keeping fixed all the other, since xj itself may depend on the others. So for instance, consider this very simple model where you have only two covariates, IOP and OPP, but of course you think here that beta 1 is the effect of IOP, but actually IOP is contained in OPP. So what happens is that since OPP and IOP are highly correlated, most of the contribution of IOP and OPP in explaining the variation of the outcome overlaps. And so the question, the problem, I'd like to underline that the problem consists in the interpretation of the estimated parameters as quantitative individual effects of the covariates. However, this problem, multicollinearity, does not hinder the assessment of the joint effect of the covariates on the response. When we have collinearity, more serious problems are as follows. The maximum likelihood estimate is not unique. There is some instability in the procedure to find the solution beta hat. The variance of these estimators beta j hat are large, and this means smaller precision in point and interval estimate of the regression parameters. And typically, we detect multicollinearity because when we use one single variable in the logistic regression to explain the probability of disease, that covariate shows a strong effect. But when combined with other covariates to explain the same response, there is no effect anymore, or there is a milder effect. And this is because individual effects overlap. Okay, so solutions. We could use a different technique that is called principal component analysis. However, we may lose the specific meaning of the covariates. Or we could remove those variables from the model, those explanatory variables from the model that explain a small portion of the remaining unexplained variation in the response using a tool which is called variance inflating factor of each covariate xj. So what's the variance inflating factor? First of all, it measures the dependency among a continuous covariate, and it is defined as the reciprocal of 1 minus R2J, where R2J denotes the value of R2 for predicting the variable xj as a response using the other explanatory variables in a linear model, of course. For those who are not familiar with linear models, I remind that R2 is an index between 0 and 1, which measures the goodness of fit of the linear model. The larger R2 is, the better the linear model is. So when xj is predicted very well by the others, in this case R2j is very close to 1, so the variance inflating factor is very large. So as a rule of thumb, we usually statisticians remove the jth covariate from the model if this number, the variance inflating factor, is larger than 10. So coming back to the analysis, I computed the variance inflating factor for all the continuous covariates in the data set, and I found that for these 5 guys, as expected, the variance inflating factor is larger than 10, while I checked that gender, which is discrete, is uncorrelated with the others. So I decided to fit a logistic regression model for the indicator of the disease, for the indicator, glaucoma indicator, with those covariates, age, gender, and heart rate, and only a few covariates among these 5. Which ones? Well, first of all, let's see what the software answer for us. This is the standard statistical software used by statisticians in all the world. So I do not have time to explain you the iterative procedure that R implements, but the models found by R contains the following intercept: age, gender, heart rate, systolic and diastolic pressure, and OPP. Okay, so this is only one among significant models. So I decided to compare all models with age, gender, and HR, and 3 out of these 5 bad guys, and I compared the model via goodness of fit tools, the IIC if you are curious, and also comparing the variance inflating factor of the current covariates. So actually I found 4 competitive good models. The best model were the ones where age, gender, and heart rate are, but there are also 4 possible models where actually I can include one of these rows. The red one is the model found by the software. The blue one is a model I'm going to show you some results, some output. So I don't think that we have time to comment on this figure. This is only a plot to see if my model is doing a good job or not. This is the plot I'd like to show you. Well, this is the plot as a function of OPP of the prediction of the disease probability for a new patient potentially joining the study with some values of the covariates. Actually, there are six patients. For all of the 6 curves, therefore 6 patients. For each patient, these are the values of age, heart rate, and systolic pressure. We have 3, the dotted lines refers to male patients, while the continuous one refers to female. And I've plotted 3 different curves because I use 3 different IOP value, which I think this is a kind of median value. This is very low and this is quite high. So you see that if we fix IOP equal to, let's say, 43, we really find very different disease probability according to the different combination of covariates. So the answer to my question, the answer is the following. It's the joint effect of all the pressure in general, of all the covariates in the selected model that determines the probability of disease rather than the value of a single, of an individual explanatory variable quantified somehow. For instance, for the same values of IOP, systolic pressure, age, gender, I found very different disease probability according to the value of IOP. So further direction, just to end up, we could, first of all, what I would like to do is to analyze more data. I mean, or more patient, of course, or data that evolve a long time. I mean, this could be really very interesting. Of course, I could consider a better model considering interaction and so on. I would like to analyze the problem using Bayesian models because it's it allows to consider a small number of patients if we have in our study a very few patients. So just to end up, many thanks to Giovanna and colleagues who provided the data and introduced me to the problem, and to a student of mine, Valentina Spagnolo, who pre-processed the data. Thank you very much.
Alessandra, thank you very much for this very detailed statistical analysis of a parameter that we've been mentioning and speaking about from population base for many years, perfusion pressure, and trying to understand it better. I think that trying to translate it to some of us that are not as smart as you with statistics, I think that basically what you are clarifying is that the use of perfusion pressure over most ranges of IOP is actually is a good tool for predicting or good an accurate risk factor for predicting glaucoma. And not, as was mentioned previously, something that is limited because these factors are connected. So, trying to put it in simple words for simple people like myself. So, thank you very much. Okay, we're going to move forward. We're going to have more time for questions later on. But we're going to move now to a lecture by Professor Szopos that will deal with understanding the interplay between intraocular pressure and blood pressure using a mathematical model. She comes to us from Strasbourg and is a collaborator of Professor Guglielmi, and look forward to your lecture. Thank you.
Thank you for the invitation. It is really a great pleasure to participate to this first edition of hopefully many of this truly interdisciplinary Congress. So today I will talk about how a mathematical model can help the understanding of this very complex relationship between intraocular pressure and blood pressure. And it is a joint work with my colleagues Simone Canzani and Giovanna Guidoboni from IUPUI and Strasbourg, with Christophe Prudhomme from Strasbourg, Riccardo Sacco from Politecnico, and also Alon Harris and Brent Sieski from the Indiana University School of Medicine. So the intraocular pressure is usually defined as the pressure inside the eye, but actually there is a nuance here, and there is an extensive discussion about this in a review paper by Kiel, because there are actually two mechanisms involved in the obtention of this value. Because first there is the balance between the aqueous humor production that takes place in the posterior chamber and the aqueous humor drainage, which takes place in the anterior chamber. And when they reach a steady state, we have this value of the pressure, which we call IOP steady state value. And there are also some IOP oscillations, which are changes in the, due to changes in ocular blood volume, but they won't be taken into account in today's talk. So why this value is important? It is because it is a elevated IOP is a recognized risk factor for vision loss, but among other, so I give here not a complete list, it can be gender, age, blood pressure, diabetes, etc. And one of the important open questions is that target value, like the normal IOP value, it is still a controversy in the clinical literature. And there is, for instance, clinical evidence of optical nerve damage and vision loss despite a considered normal IOP value. And there are also patients for whom they had a treatment to lower the IOP till this targeted value, and they still experience disease progression. So in order to understand this kind of variability, it is important to have this individual specific basis understanding of the relative contribution of each risk factor and potentially of different combination of these risk factors. Other open questions are related to the IOP lowering medication and their efficacy. So they act through different mechanisms, either by reducing the aqueous humor production or by increasing the aqueous humor drainage, or acting on both mechanisms. However, there is once again a lot of variation among individuals, and I'm giving here a few examples. There is clinical evidence that the lowering effect is more significant when IOP is higher, for instance. There are also clinical evidence showing that the lowering effect changes through the circadian rhythm. So in order to devise the most effective treatment for each patient, it is important to determine the efficacy, or what are the factors affecting this efficacy. So how can one answer these questions? There are different approaches, either clinical studies or animal studies or statistical analysis. So for the clinical studies, the advantage is that we have direct access to human data. But the difficulty, as we saw in the previous talk, it is to really assess this factor separately in vivo. As for the animal studies, they are much more controlled. But of course, there are all the differences in the anatomy and physiology among species. All the methods from statistical analysis can give you a lot of interesting information about how can these data correlate, but it is difficult to have cause-effect assessment. And also there is a difference in the statistical method that we can use for the problems. And this is why today I would like to propose, in synergy with these approaches, a mathematical model approach that we base on the principle of physics to complement the information that we have with the other approaches. So for this, the mathematical model we put into place, it's a network-based model. It is based on the analogy with electric currents. And so you have there a schematic of our model, which is consists in two blocks. You have in the blue part the aqueous humor block, where we describe the production through two mechanisms, ultrafiltration and active secretion. We also describe the drainage through the two classes. So the first one, it is which is considered the conventional drainage pathwork, the trabecular meshwork, and also the non-classical uveoscleral pathway. They are both modeled as nonlinear resistors. Secondly, we include in our model a black flow plot, all the black part in the scheme. There are three vascular beds included in our model. There is the choroidal, the ciliary, and the retinal vascular bed. In the three of them, we included a Starling resistor effect for the veins. And also for the retina, we took into account the effect of the lamina cribrosa on the retinal vessels. These two blocks strongly influence, they are strongly coupled in the following sense. First of all, the IOP acts as an external pressure on the intraocular veins, and thereby they impede blood flow. On the other hand, blood pressure, it is the driving force for the blood flow, and this contributes then to the production and drainage of aqueous humor, and therefore it is the IOP value that it is directly affected by the blood pressure value. So what can we do now with this model? First of all, in order to validate our computations, we reproduced some experiments described in the clinical literature. In this case, there was an increase of a certain value in the systolic blood pressure, diastolic blood pressure, and then IOP values were reported, and we compared these values with the values of the results of our simulation, and it is really very well compatible. We fit in the same ranges. Then there was very interesting, I found this interesting discussion about the precision, the fact that it is difficult to interpret just numbers, and there is a lot of uncertainty in all these values. This is why further on we included a stochastic analysis to include the uncertainties due to different reasons. And what we did, we considered the uniform distribution within physiological ranges of different selected inputs in our model, and we monitored the frequency distribution in the IOP value. And then on the upper side, left upper side of the panel, there are the results of the simulation, and on the lower side there is a result of a study including more than 12,000 patients that was reported in the literature. And as you can see, the curves are in very good agreement in the sense that it is a Gaussian curve, is skewed to the right, and it tails off to the higher pressure. And it is exactly what was observed in this very large study on more than 12,000 patients. Now, we wanted to make a step further and also assess the influence of some selected inputs through a mathematical method called the global sensitivity and global stochastic sensitivity analysis. In this method, we compute quantities called Szopos indices, and these indices, at the first order, they quantify the direct influence of each selected input. So here on the left side in dark blue, I plot the first order Szopos indices and their influence on the IOP. So as you can see, what is the main influence? It is the total inflow facility and the trabecular meshwork outflow facility. Then you have a milder influence of the blood pressure through MAP. And what it is really minimally influencing IOP, it is the uveoscleral facility, which is normal because it is what is in clinical case reported. Also in light blue, I plot the total Szopos indices, which is something, it's a mathematical index taking into account the interaction between all these inputs. And here what you see, it is the values are pretty close to the first order indices, which means there is almost no interaction between these selected inputs. So this would be very interesting to correlate with your findings from the statistical viewpoint on real data and to see what kind of information we can put together and have a better understanding. of what happens. So further on, we wanted to see what is the effect of IOP lower medication through different conditions, but for this we had to design some theoretical patients, in the sense that we have ocular hypertension, which is defined as elevated IOP, and actually at the molecular level there is still a debate in the clinical literature on what produces ocular hypertension. But as far as we were able to have information from the clinical papers, it is the reduced outflow, aqueous humor outflow, that is responsible, rather than the the increased production to have ocular hypertensive patients. So this is what we used in our simulation, in our mathematical model. You have here a graph showing how we obtain, by reducing the trabecular meshwork outflow facility, we increase IOP, and this we did it for 3 different values of blood pressure in order to see also the nonlinear effects of the variations in blood pressure on IOP. And now, if on these 3 theoretical patients, we study what are the model predictions on the effect of IOP lowering medication, we tested both a 20% increase in total inflow facility, a decrease in total inflow facility, and we compare it to a 20% increase in total outflow facility. And from this panel, the model predicts that actually reducing, when we decrease the total inflow, this is more effective than increasing total outflow facility. And there is also a nonlinear effect of the blood pressure influence on this IOP lowering efficacy, knowing that, as you can see here, when IOP lowering is more effective, when MAP is higher, actually. But in both cases, but more effective when we act on the inflow facility rather than on the outflow facility. So, just to resume the findings of this study, we proposed a 2-block coupled model. This model is able to do until now? It was able to reproduce the healthy conditions, and we assessed this through clinically reported data. And we also applied it on theoretical ocular hypertensive patients. And when simulating the effect of IOP lowering medications, we have the following predictions: that the IOP lowering is more effective when the total inflow rather than the outflow facility is altered, and all this dependency varies in a strongly nonlinear way when comparing to the blood flow, to the blood pressure influence on this efficacy. So, of course, all the talks I had here are very inspiring, and there are a few next steps that we want to include in our modeling. At the short term, we want to add autoregulation, because we know that it is a very important factor on compensating the changing mechanisms, and that it was already done for the retina in a recent paper by Giovanna Guidoboni and its collaborators. So we want to extend it for the whole vascular bed. Then there is also another issue about the scale to which we are looking at this phenomena, because here we looked at the ocular tissue scale. It's a coarse level, but we want to couple this with what happens at the cellular scale, and you will have more details in a talk by Aurelio Mauri this afternoon to see how these 2 models fit together. And also there was the third actor, the intracranial pressure, and this is something we also want to include in our model, because it is the pressure behind the lamina cribrosa, which is related to the CSF pressure. We need to include this in the model. And this is what we are doing in the Eye2Brain project, a project we are jointly developing between IUPUI and the University of Strasbourg. And my colleague Christophe Prudhomme will give you some insights about the expertise we have in Strasbourg for blood flow modeling this afternoon. So, in the end, just thank the co-authors, collaborators, funding source, and thank you for your attention.
Thank you very much, Marcela. This was very inspiring, and
You are
thank you. So One of the unique goals of this conference is indeed having clinicians sit down together and discuss with engineers and physicists and statisticians a different view or understanding better these risk factors and the pathophysiology. So we've heard now some very interesting talks that came from our scientists. We're now going to move to a clinician scientist, Professor Quaranta, who I know for I think 20 years already.
25.
Yes, we're getting old certainly. And he is going to talk to us about 24-hour IOP fluctuations, myth or reality. So you're going to hear a clinical view, and then at the end we can put this all to debate. Luciano, please.
Thank you, Alan. It's a great pleasure to be here. Yes, we know each other of almost 25 years, and we have dealt in this period with a lot of problems related with intraocular pressure, blood flow, and my feeling is that all these things are strictly related in the pathogenesis of glaucoma. But up to now, the only risk factor that has been clinically validated for the onset or progression of glaucoma is intraocular pressure. We have a lot of data about intraocular pressure, but we lack also a lot of data about the behavior of intraocular pressure and the relationship between intraocular pressure and progression of the disease. From a clinical point of view, we are used to measure intraocular pressure during office hour from 8 a.m. to 8 p.m. And so in order to understand this, the behavior of this risk factor in determining the disease and which is the best candidate to intraocular pressure phasing is a glaucoma patient in which, in spite of an apparently normalized intraocular pressure, the disease is still progressing. Or we want to check if a particular therapeutic regimen is enough to reach target IOP, and in other words, the intraocular pressure we desire in order to avoid progression of the disease. So, from a clinical point of view, we take our patient to the clinic, we measure intraocular pressure, and we determine a behavior and a phasing of intraocular pressure throughout the office hour, and even when it's possible, but clinically it's not possible, throughout the 24-hour. So 24-hour IOP phasing is mostly relegated to glaucoma research, and from a clinical point of view is not feasible and is not applicable to our patients. Before we move over in this talk, I want to show the gamut of terminology relating to 24-hour intraocular pressure phasing. We speak about diurnal fluctuation, that is the diurnal variation of intraocular pressure we measure in our glaucoma patient. Nocturnal fluctuation is nighttime IOP variation. Circadian fluctuation is IOP variation measured throughout a 24-hour cycle, and short-term and long-term fluctuation. And this is the hot topic of glaucoma research in the last 10 years, and which is the intervisit IOP variation measured across days to months, and long-term fluctuation intervisit IOP variation measured across months to years. So we have a wide range of terminology, and we are going to get familiar with that at the end of my talk. And you can find all this information in our recent publication. What we know about intraocular pressure fluctuation? We know that also in normal subjects, intraocular pressure tend to fluctuate from 4 to 6 millimeters of mercury throughout the 24-hour. But which is the behavior of intraocular pressure? We see that if we measure intraocular pressure in sitting position during the day, we see this small fluctuation of intraocular pressure. But if we measure intraocular pressure during the night in supine position, you can see an abrupt increase of intraocular pressure during the night time in supine position. But if we measure intraocular pressure in supine position throughout the 24 hours, you can see that there is no change, no significant change in intraocular pressure during the night time. So it has been demonstrated that intraocular pressure increased during the night time due to an increase of pressure in the episcleral plexus. So it just determined by the change of position. And we know that during the night time there is a decrease of aqueous humor production of about 50%. In spite of that, there is an increase of intraocular pressure. So we know that changing position increases intraocular pressure. The same, it has been demonstrated also for ocular hypertensive and glaucoma patients. We have demonstrated that intraocular pressure tends to increase during the night time in supine position, and we can predict this increase of intraocular pressure during the night time simply measuring intraocular pressure in the morning in supine position. So we have created a surrogate of intraocular pressure measurement during the night time in order to avoid 24-hour IOP phasing, and we can measure intraocular pressure in supine position in the morning, early in the morning, in order to have a good surrogate of the behavior of intraocular pressure during the night time. From this investigation, we have demonstrated that 2/3 of glaucoma patients have increase of intraocular pressure outside the office hour. So in some cases, it can be interesting to measure intraocular pressure also during the night time, or having in this case, a surrogate of intraocular pressure, nighttime intraocular pressure, by putting the patient in supine position and measuring intraocular pressure. This behavior has been demonstrated also in healthy controls. What we know about short-term fluctuation. This is a work, a paper published by the group of Bob Ryreb. It has been demonstrated that normal subject tends to fluctuate more than glaucomatous subjects. As you can see, this is normal subject, this is glaucomatous patients. It has been demonstrated that normal subject tend to fluctuate more than glaucomatous patient, even if also in glaucomatous patient there is a tendency to increase of intraocular pressure during the night time in supine position. Which is the clinical importance of this? We don't know because we don't have clinical trials, randomized clinical trial that has been demonstrated that fluctuation of intraocular pressure throughout the 24 hours is an independent risk factor for progression of the disease. But we know that when we want to reach a determined target IOP, we try to flatten the 24-hour IOP curve in order to avoid fluctuation, in order to have the most stable possible intraocular pressure curve. As regard long-term IOP fluctuation, we know that intraocular pressure is not a static variable and it tends to variate through the time, through the 24 hours, but day from day, month to month, year to year. What we know from the literature, which is the role of a long-term IOP fluctuation. The only study that has demonstrated in a post-hoc analysis that long-term fluctuation are a risk factor for progression of the disease is the AGIS, is Advanced Glaucoma Intervention Study, that has demonstrated that more stable is the pressure and lower is the pressure in a long-term follow-up, and lower is the probability of progression of the disease. This is an important data because we know that lowering the pressure is important, but it is also important to have a lower pressure throughout the time. So to have a stabilization of the intraocular pressure in the long term. We know that glaucoma is a chronic disease, so we have to measure pressure, stabilize pressure, but not just for a day or for a month, but for all the life of our patients. In a post-hoc analysis, Caprioli and Coleman has demonstrated that this is true, but only for patients with very low intraocular pressure. So patients with very low intraocular pressure, if they have fluctuation less than 3 millimeters of mercury, have a good stabilization of a progression of the disease, in spite of patients that tends to fluctuate in the long term more than 3 millimeters of mercury. And this is a graph that it has been reanalyzed by Coleman and Caprioli, and then it demonstrates that fluctuation, long-term fluctuation of intraocular pressure are not beneficial for the progression of the disease. What about all the other studies? The early manifest glaucoma trial, the Malmo ocular hypertension study, the European glaucoma prevention study, the ocular hypertension treatment study have failed to demonstrate that intraocular pressure fluctuation are independent risk factor for the progression of the disease or for the conversion from the state of ocular hypertension to the disease glaucoma. But which is the limit of all this investigation regarding IOP fluctuation, that none of this disease was designed with this purpose. So it is possible that we need a specific clinical trial in order to investigate which is the role of IOP fluctuation, short-term and long-term, in order to determine if they are independent risk factor for progression of the disease. What about short-term fluctuation, the fluctuation that occurs during a day? The only works that we have, prospective works, is the works of Asrani that has been demonstrated that short-term IOP fluctuation are independent risk factor for progression of glaucoma. This study has never been replicated and has several problems. First of all, IOP was determined prospectively and visual field were analyzed retrospectively, so this is a major bias. The other problem was self-tonometry. Patients were asked to measure at home intraocular pressure, and so the reliability and repeatability of this kind of tonometry has been never demonstrated. So, but this is the only study that we have about the role of short-term IOP fluctuations and progression of glaucoma. In a retrospective study, we have demonstrated that, with the limit of a retrospective study, that patients with at least 5 years of follow-up with 24-hour IOP assessment, we have demonstrated that higher is the mean IOP throughout the 24-hour, and higher is the probability of progression. So we have not demonstrated anything because we know that patients with lower intraocular pressure, as demonstrated by the ages, and mean intraocular pressure, and lower is the probability of progression. But we have shown that also 24-hour assessment is in line with other big, very large randomized clinical trials like the ages. So it is important, and from this study and other study, it is important to determine that the major risk factor for glaucoma progression is the higher mean intraocular pressure, as determined as a single measurement throughout the time, long-term fluctuation, or throughout a diurnal or a 24-hour curve. So which is important for a clinical point of view? Peak, mean, or fluctuating intraocular pressure. Despite the fact that there is no conclusive evidence to show that there is a strict relation between fluctuation of IOP and glaucoma progression, there is considerable interest in the former. And the aim of management of glaucoma should target to favorably modify all three parameters. So to reduce, to avoid peaks, to reduce mean intraocular pressure, and to avoid fluctuation. So it is important to try, our target of therapy, to try to flatten as much as possible intraocular, the diurnal curve, and to try to avoid fluctuations. But this is just a clinical impression, but because we don't have any evidence, scientific evidence, about 24-hour IOP fluctuations. From a practical point of view, we can measure intraocular pressure by measuring intraocular pressure in 4 measurements throughout the day, from 8 a.m. to 8 p.m., and measuring, as I showed you before, the first intraocular pressure measurement at 8 a.m. in supine position. So we can have a good surrogate of intraocular pressure during the night time. But is enough to measure, to have a 24-hour IOP curve, 24-hour IOP phasing? No, this is not, because it has been shown by the group of Weinreb, Tony Realini, has demonstrated that there is a huge variability of intraocular pressure measurement throughout the day in different days. So sometimes we need to repeat a diurnal phasing in order to be sure that our treatment is efficacy, has a good efficacy, or if we think that intraocular pressure is normalized or apparently normalized in 1 day and after 1 year, it seems not. So we need to repeat the diurnal curves in order to understand which is the clinical development of the disease. From a practical point of view, we can also measure intraocular pressure in different visits in order to build a phased diurnal variation and to understand which is the behavior in the long term of intraocular pressure. And this is very interesting because, as I showed you before from the AGIS, the Advanced Glaucoma Intervention Study, is it important to understand which are the fluctuation of intraocular pressure in the long term, because this is an important risk factor for the progression of the disease. And from a clinical point of view, it allows us to build a diurnal, a phased diurnal curve in order to understand which is the behavior of intraocular pressure, avoiding time-consuming and expensive incoming patients in the clinic, or also for the patients and the clinician. So, in conclusion, the IOP should be measured at the same time of the day before and after initiating therapy. This is important in order to understand which is the behavior, the efficacy of the therapy. It's very difficult to measure intraocular pressure, phasing intraocular pressure during the day, as it is almost impossible from a clinical point of view in the 24-hour. So 24-hour IOP phasing is also just limited to research in order to understand the behavior of intraocular pressure and the efficacy of treatment on our glaucoma patients. It is important to repeat diurnal IOP recording in case of patients to continue to deteriorate, in spite of an apparently normalized intraocular pressure, because sometimes we measure pressure today and after a determined lapse of time, intraocular pressure is completely different. And phase IOP records and office time IOP records might be considered as an alternative. Very last conclusion is that IOP is not a static number, and it tends to fluctuate over the life of all of us and our glaucoma patients. And I think that the most important predictor of glaucomatous structure is mean IOP, and a desired therapeutic target is therefore a uniform reduction of IOP throughout the 24 hours. Thanks for your attention.
Thank you, Chair, very much for this very nice overview and update of intraocular pressure, the importance of the diurnal variations, long-term fluctuations, short-term fluctuations, and then this, I'm sure, is helpful for many of the scientists who are trying to put this together in the scheme of the different models. Continuing to the last speaker of this session, also coming from the clinical perspective, also a good friend from Italy, Professor Michele Iester, who comes from us from the University of Genoa. He's going to talk to us about different IOP in different diseases, and he's a perfect person to talk about this, as he has a background not only in glaucoma, but also in uro-ophthalmology, and can try to put some things in perspectives for us in this regards clinically.
Well, I would like to thank Here you go. for the invitation, and also Giovanna Guidoboni for the invitation. So, glaucoma is a progressive chronic disease with a typical optic nerve head changes and a visual field defect, with an intraocular pressure too high for the well-being of the optic disc. So we can have a glaucoma patient with intraocular pressure at 16 or 20, 25, and so on. This is an example of glaucoma patient. Here the optic disc with a thinning of the rim and the loss of retinal nerve fiber layer in the inferior sector and the correlated visual field defect in the superior sector. So from the literature we know that the mean intraocular pressure in the population is around 16, 17. And if we want to calculate 95 interval confidence, we can obtain the number of 21, the magic number that help for many years physicians to classify healthy people when the intraocular pressure was below 21 and ocular hypertensive or glaucoma patient if the pressure was higher. And if the pressure was higher than 21, the patient were classified as high tension glaucoma. Below, if they have a glaucoma, optic disc change, patients were classified as normal tension. Also, the EGS, European Glaucoma Society guideline, give us a definition of primary open-angle glaucoma, high tension glaucoma, high pressure glaucoma, has a symptomatic disease at the beginning, elevated intraocular pressure, and change in the optic disc and the visual field, and of course, open angle. And a very similar definition is for normal pressure glaucoma, asymptomatic disease at the beginning, normal intraocular pressure without treatment, this is the only difference, and after optic disc damage, visual field damage, and open angle at the gonioscopy. Another point that we have to remember is corneal thickness. We know in the last year that corneal thickness can change a little bit the value of the pressure. The thickness, the elasticity, and the structure of the cornea can create a kind of misreading of IOP when we made an applanation on the cornea to take a pressure. So if the cornea is thicker, the IOP value will be higher, while if the cornea is thinner, the intraocular pressure will be lower. But for this moment, in the literature, there is no formula able to calculate okay, thanks. There is no formula to calculate the real intraocular pressure. So we have to consider central corneal thickness has a confounding factor or a prognostic factor. This is another example of glaucomatous optic disc, and here you see that the rim is lost, so inferior loss of the rim. Here, these other two optic discs with some peripapillary hemorrhages, the superior and inferior, and as Jonas suggests, when we have some peripapillary hemorrhages, we have to think about glaucoma, in particular normal tension glaucoma, but we have to also think about diabetes or vitreal detachment or other disease, just to be sure. This is another example of loss of fibers in glaucomatous optic disc. So for many authors, glaucoma, normal tension glaucoma is a particular type of glaucoma with a particular optic disc damage and a visual field defect. And this is the literature that, in which we can find this kind of definition. And in this paper, we can find this type of description of the loss of of the rim in the inferior optic disc with a superior scotomata. And here another example with a paracentral scotoma. And here with a GDX, that is a retinal nerve fiber analyzer, loss of fiber in the inferior sector with a superior paracentral scotoma. There are another group of physicians that think that normal tension and high tension glaucoma are the same disease, and here other authors. And in particular, I didn't find any different when I compare a normal tension glaucoma optic disc to high tension glaucoma optic disc by using HRT, that is a confocal scanning laser. And for all the parameters, we didn't find any difference in the two groups. And also when we compared a group of normal tension glaucoma with a group of high tension glaucoma, we didn't find any difference when the analysis was point-wise. Otherwise, we found some difference, but not in the central area of the visual field when we compare the two groups by using some cluster. So, no difference in paracentral scotoma, in paracentral area, as the other author describes in the literature. So, these are two optic discs with different characteristics, but both has glaucoma. And as Drans described in many papers, we could try to identify different types of glaucoma just looking at the optic disc. For instance, this disc has with more hemorrhages and with notching in the inferior, it's called focal ischemic glaucoma. And this other disc with a concentric enlargement of the cup is another type of glaucoma characterized by a very high intraocular pressure. And in this paper, Drans and Nicolela found 4 different types of glaucoma just looking at the optic disc, the slide of the optic disc of 100 patients, and they were able to classify in 4 different groups, and the interesting thing that these 4 different groups has different risk factors that were statistically significant among them. Another study from Drans and Schulzer found that in which they analyzed the risk factor, age, mean deviation at the baseline, some kind of antibody, intraocular pressure, the mean of intraocular pressure, the standard deviation, and the gender. And they obtained, using this kind of statistical analysis, they obtained 2 different groups, cluster 1 and cluster 2. The point are black are high tension glaucoma and white are normal tension glaucoma, and the cluster 1 were characterized by a low finger blood flow. Otherwise, the cluster 2 were characterized by increase of fibrogenin, low HDL, and some other clinical characteristics. So this suggested that the intraocular pressure is important, but not fundamental to divide these 2 types of glaucoma, normal tension and high tension. And in another analysis, always in this study, they were able to correlate the cluster 1 with mean deviation, and cluster 2 again with mean deviation, but as you can see, the correlation was weaker than in the first case. So when we have a patient with a typical optic disc, a typical glaucomatous typical optic disc and visual field, and a very high intraocular pressure, the diagnosis is very easy to do. But when we have a patient with a normal intraocular pressure and typical optic disc and visual field damage, we have to think also to other diseases, such as inferior optic nerve coloboma, or congenital optic nerve head pit, or tilted optic disc that can give you a typical archiform scotoma. Another thing that we have to think about before the normal tension diagnosis is to be sure that the visual pathway are healthy. So an MRI is useful. This is a study that has been published in the Journal of Glaucoma, in which the author compared a group of normal tension glaucoma with high tension glaucoma. And they found that in normal tension glaucoma, 6 patients had MRI positive, while in high tension glaucoma, only 1. And 4 were clinically significant, and the patient had an intracranial lesion, as we described. And here you can see that the visual field of this patient were very similar to typical glaucomatous damage. And again, another case, and another with nasal step and inferior quarter scotoma. So, another point that before a normal tension glaucoma diagnosis, we have to think of the progression of the damage. We have to remember that there is a very good correlation in glaucoma between the optic disc damage and the visual field defect. But we have to remember that capping is also present in some other disease, like anterior ischemic optic neuropathy or post-traumatic optic neuropathy and so on. So this is the first point to keep in mind. And the second is to find the progression. Glaucoma is a progressive disease, so we have to find a decrease of the function or of the structure in the follow-up of the patient. And here 2 examples of 2 different linear regression analyses. And here an example. You can see here a little hemorrhages in the inferior optic disc, and after some years, the hemorrhages, of course, is not anymore present, but we have a paracentral scotoma. So this is a table from ophthalmology in which the authors try to test the sensitivity and specificity of some clinical parameter. They didn't find any very good parameter able to predict glaucomatous optic nerve head capping. And in the same table, in the same paper, they also try to look for a good parameter for predicting non-glaucomatous optic nerve head capping. And also in this case, they didn't find a very good parameter in this study. So in conclusion, high tension and normal tension glaucoma are, in my opinion, very similar disease with just a different IOP value. Different types of glaucoma exist and are probably based on different risk factors, as blood flow. And the differential diagnosis is fundamental to understand to make the right diagnosis. Thanks for your attention.
Michele, thank you very much for educating and reviewing regarding normal tension glaucoma, primary open-angle glaucoma, and the different clinical views. I'm going to invite the speakers of this session to please come up to the podium, all the speakers, and we will have an opportunity for some questions. I'm reminding everybody that we're going to have a coffee break, and there's posters, some very nice posters of students from different, as well as faculty from around the different world. There's people here, again, from 30 different countries. And there's some very interesting presentation and different views combining scientists and clinicians. The next session that we're going to start will start actually with Dr. Constantino will be the first speaker. So the distinguished platform of speakers is now open for questions. And we have a microphone that will go around. Yes, Peter. Will you please identify yourself when you speak, so we know who we have.
Peter Koch Jensen from Copenhagen. It has been about 30 years ago that Morris Langham proposed that beta blockers were detrimental, and now we have had more antihypertensives coming along, and the practitioners are treating blood pressure more aggressive. Have you any correlation to what kinds of antihypertensives are being used and detrimental? Are the beta blockers still a villain? What about the new ACE inhibitors, calcium channel blockers? Are there any of them we should try to convince the practitioners to avoid?
It has been demonstrated that the use of beta blockers and also calcium channel blocker from the AGPS and also diuretics from the GPS are a risk factor for conversion from ocular hypertension to glaucoma. I have some doubts about really if ocular perfusion pressure is a good indicator of blood flow at the level of the eye, because it's so strongly modified by intraocular pressure, and also the mean variable is blood pressure, because there are two main differences between the two, but I'm not so sure that is a good surrogate to measure blood flow at the level of the eye. We know from large randomized clinical trial that reduced diastolic ocular perfusion pressure is a risk factor for progression of the disease. But I think that we need to have a more detailed, and from all the lectures that we have heard this morning, we need to have a more precise indicator of what happened at the level of optic nerve, of retinal ganglion cells, to determine if just a simple reduction of blood pressure or of ocular perfusion pressure is a real risk factor for glaucoma.
Yes, thank you, Luciano. Anybody else? Maybe, Peter, I can add. I think what Peter is saying is also, in addition to your interesting comments, is are some of these beta block or some of these systemic antihypertensive medications lowering blood pressure and or perfusion pressure, and then, as Luciano said, affecting circulation to the point where this can be detrimental. And I can only refer here again to the Saloniki Eye study, that where in the Saloniki Eye study, again, it was the combination of the low blood pressure together with the systemic antihypertensive medications, that when you stratified the data, that's where you saw changes both in the paper in 2006 and then in the follow-up paper in 2013 on glaucoma patients, which correlated with some structural damage. So we then tried to go back with Fotis Topuzis and with Roy Wilson to try to look at the subgrouping of the systemic medications, like you are rarely alluding to. Is there a difference between the beta blockers and the ACE inhibitors and the calcium channel blockers? And unfortunately, we heard some great lectures from statisticians today, and we didn't have enough data in the cells for the different medications. But I think that remains to be seen. Maybe some systemic antihypertensives are worse than others.
Yes, but if you mean from a clinical point of view, I perfectly agree with you, but we anecdotally say some patients in which you strongly reduce the blood pressure and you see progression of the disease. We need to have a strong predictor in some randomized clinical trial to stratify, to understand which is the best indicator for progression of the disease. But we know from a clinical point of view, if you have some patients in which blood pressure is very, very low and intraocular pressure is well controlled, sometimes you see progression of the disease. So we have to interact with general medicine GP in order to avoid that the blood pressure is too low in our patients.
So we have two speakers that have raised up. First is our friend from India, and then Professor Miglior. So maybe you can go first, and then Professor Miglior.
I'm Professor Meenakshi Dhar from India. I think what he was alluding to was that whether a patient is taking calcium channel blockers or beta blockers, the effect would be different, because the beta blocker would decrease the IOP simultaneously decreasing the blood pressure, while a calcium channel blocker will only decrease the IOP. And from what I remember, there were some studies which said that it actually has an adverse effect on the IOP. So when the clinician is giving the physician is giving a calcium channel blocker, one has to remember that more, and the timing of giving the medication. All we can probably from what is given is we should probably take the antihypertensives more so in the morning rather than in the evening to avoid the dip in the night.
Stefano?
Data about the perfusion pressure and the development of glaucoma are very, very rare. Actually, to my knowledge, there are 2, maybe 3 with the Thessaloniki. I'm not really sure about the Thessaloniki, but you can tell us more. And are the EGPS and the Rotterdam eye study. In both studies, one is a clinical trial, the other one is a population-based study. 2 types of drugs have been associated with the development of glaucoma, and were the diuretics in our study in the GPS and the calcium channel blockers in Rotterdam. And however, our interpretation, at least in the GPS, was that we cannot rule out the role of the diuretics, but we strongly think that was just the idea of a very aggressive treatment for hypertension. In fact, also the association of several drugs to treat hypertension had a higher hazard ratio, was about 2 or even more than that. It was not statistically significant just because the power was not enough. But anyway, the trend was there. And so we believe that anyway, these findings are consistent. And also in Thessaloniki, you found very, very similar results. And we cannot avoid looking at these clinical parameters in our practice, because it's really, really very important.
Stefano, do you think that perhaps is more a comorbidity of this? We think that some patients in which you have associated general vascular diseases, you are more likely to progress instead of patients that are healthy. So
yes, it is possible.
Taking drugs is a surrogate to understand that these patients
it is possible, and as Alon knows very well, probably it's very difficult to see, maybe the mathematicians may help us in this, that it's really a problem in autoregulation, because in these patients affected by systemic hypertension, the resistance, the arteries are very stiff and they autoregulate much less. So when the blood pressure goes down, there is no way. The system cannot auto-regulate anymore, or much less, and so that is probably the reason, but for us it's very difficult to prove it.
No, absolutely. I mean, one needs to, in continuation to your comments, one needs to take into account who are those people that are taking systemic antihypertensives that came out statistically to be significant with a low blood pressure. These are patients that had high blood pressure, who knows for how long. Maybe 10 years, maybe 15, maybe 20, and they suffered from atherosclerosis and from vascular conditions that, as you said, impair their ability to autoregulate anyway. So you give them the systemic medication, you lower blood pressure, and then you have a condition of low perfusion pressure that was referred to with lack of ability to perfuse those vessels. So Dr. Wegner.
I just want to go back. We have the clonidine that we don't use anymore, but it was a side effect of lowering the blood pressure and losing visual field, and that's why it's the same thing.
Absolutely. Any other questions for the rest of the panel?
I just can make a comment of what we need, an unmet need. Perhaps we are speaking about lacking of autoregulation, but we need an exact formula to determine which is ocular perfusion pressure, even in sitting and supine position, because we just refer to very lacking to very less adherence to reality formulas, but we know that the problem is really more complex. So perhaps an unmet need is really to calculate perfusion pressure at the level of VI in a clinical strict manner.
Sorry to disappoint you, a strict formula.
Press.
Sorry to disappoint you, actually a strict formula won't be available, but what we can propose as a complement to your knowledge in the clinical studies is a mathematical model that will relate blood pressure and IOP and take into account uncertainties. And this is one step further because like precise figures are very difficult to measure, to obtain, and to compute from our viewpoint. But a mathematical model relating these two pressures and a third pressure, like the CSF pressure, as the following step, would be important to elucidate these highly nonlinear connections, because it's not like as easy as say 10% of modification we give 10% modification in the other one. It's not the case at all. So our efforts are going to that direction.
Giovanna?
I wanted to follow up on that comment and say that, as Alon was saying yesterday, any conclusion from a math model is as good as the assumptions you put in. So for us, for us as modelers and mathematicians, it is extremely good to hear from all the clinicians in the room the different hypotheses, the different conjectures, because in order for a model to be fair and to be used to actually test the different hypotheses, the model needs to contain all the possible ingredients, that you doctors conjecture that can affect the system. And then once that is, it cannot be comprehensive, but the more, ingredients we put in, then we can hope to assess the relative importance of different factors, which my personal opinion is that they will not have the same importance over the whole day, over the whole population, over the whole age, but if we have the ingredients on, we can test it.
So absolutely, while the microphone is going around to Professor Riccardo Sacco, the point is that maybe this type of approach, combining the clinicians and all the scientists here, is going to help the trend in medicine, which is to individualize and tailor-make specific treatment modalities that would be suitable for some glaucoma patients, for example, as you related to, for example, Michele, but not for others. And this approach might be helpful. Ricardo?
Oh, thanks. Just to the final comment, it seems also clear to me that clinicians and mathematicians today have pointed out let's say, the focus on different scales. I mean, you have some people here connected disease with calcium or beta blockers channels, in this case. So channels are related to a very fine scale, a cellular level, whilst other parameters that have been considered as relevant in order to quantify disease or not disease are at a, let's say, coarser scale, something which is more touchable, visible. So from the mathematical standpoint, it is really not easy at all. That is something that we are going to do, and this is necessary in some sense, to build up a connection. And particularly Professor Marcela Szopos has pointed out that today you have the chance to listen to another talk, which will be a sort of counterpart, a complement to what she has been discussing at, I would say, course scale level. So it is beautiful, as Giovanna pointed out, to hear the point of view of clinicians, physicians, in order to, let's say, have more input, more strategies for us to develop a whole scale model, I would say, multi-scale, full-scale model. So, because the effects, the mechanisms that underlie and govern all of this complicated stuff are located at cellular and arterial level, so it's really very complicated to, let's say, to provide a unified framework to account for all of these combined effects which are clearly occurring at the same time in the body, and of course, they depend, if I understand correctly, from the fact that you might have a normal pressure, but this comes out from taking medicines, drugs, or you might be fortunately healthy by yourself, which is completely different. And so that is another input that in a model is not obvious at all to take into account, because the numbers are the same, but the history behind them appears to be completely different. So this is, I'm not a medical doctor, unfortunately, but I feel that this is another important input.
Excellent. Stefano?
Actually, just going back to what you were saying, and it's difficult, but it's much more difficult than what you think, because they are not stable numbers. They change continuously. It's really impossible to find out which is the real number you should rely on. So as Luciano was showing today, or we know very well, IOP and blood pressure change continuously. And if we add also the CSF, at least we may measure IOP and blood pressure at certain points. But what about CSF? Yes, maybe there are some machines that may help us, but it's very difficult for. So anyway, you will have to work a lot about it.
One more comment, one last comment. Okay, two last comments. This is generating a lot of questions and interest, and this is why we're here. So,
yeah, thank you very
please
much.
Please identify.
To all of you. Mine is not really a comment or a question, is just a provocation to the doctors, to the clinicians, made by the point of view of those who build up the models and who simulate something that happens in the biological system in a human based on your data. You want an exact equation or just something that gives you a number. Okay, that's fine. We are capable and we can do this. But what we need are reliable data, are reliable measurements that I know I'm fully aware that fluctuations in pressures are continuously varying during the day, and this is a fact. So what we need to build up reliable models is to have some sufficiently reliable data measured on the patient. Based on that, we can develop and do any statistical analysis on the big amount of data you will provide us, and then we will give you the equation. But the equation per se is absolutely useless if it is based on not reliable data. Thank you.
If you think that we realize that reducing intraocular pressure is beneficial for glaucoma no more than 10 to 15 years ago, because before we know that reducing intraocular pressure was beneficial, but we didn't have any scientific evidence about that. We have to wait for some large clinical trials. So I'm not searching for, my name is Quaranta, so it's a number. And the right person for that, but I think that we don't need an equation, but we need to tailor, like Alan was saying, to tailor for each single patient or group of patients a specific way of measuring risk factors. And we don't need a number. We need to know that a particular risk factor is more related with the disease and how we can modify risk factor for the disease. So we don't need an equation. We need an interaction between two of us in order to understand which is the best way to manage it.
Last but no, thank you, Luciano. I think you made that very clear. And I think your comment is very interesting and really puts the weight on the data acquisition part. No, there's a lot of inaccuracies. The technology is still not as sensitive and precise as it needs to be. We've heard some techniques that are certainly heading that way, and I really enjoyed the presentations on the technology today, both on the measurements of the ICP and the perfusion pressure, and the fact that you're following rigorous ways to try to achieve a technique which is non-invasive but precise as well. So last comment by Francis, I think you... Oh, okay, okay, so...
want to take a last
Yeah, we take one last comment, and I don't want anybody to feel like they're not represented here.
Francis Meyer Gibbon, Switzerland. I'm a pure clinician ophthalmology, and I'm fascinated by the mathematical models you all have, but dealing with patients, thousands of patients, I just tell you, we are dealing with live tissue, we're dealing with patients who do a visual field and they have a headache and they don't do it the correct way. We deal with measuring IOP with slit lamps, with a study showed in France 70% were decalibrated. Yep. So they were not correct, they didn't measure correct. We're dealing with measuring IOP in a way with Goldman, which is not correct at all. So, you know, I think it's fascinating, but we have to be careful. We cannot take a mathematical model and put it into the live tissue.
And once again, as was said before, and I think people are sensitive to it, the models are as good, and I said it in my presentation yesterday, as good as what we put in them. So yes.